I'm grateful that everybody's able to attend this particular special seminar that we have today. My name is Robert Strack. I'm the department head for experimental and clinical pharmacology, and I'd like to welcome everybody here. It's my great pleasure to welcome all of you to our guest speaker, Dr. Reinhold Vieth, who will be introduced more formally by my colleague, Dr. Richard Kingston. Today's event represents CCP's third toxicology seminar, which is sponsored by the Speedy Safety Call Endowment Fund. The intent of this toxicology seminar is to bring in nationally and internationally recognized speakers. We're leaning on the ladder here with an international speaker today to talk about appropriate topics which for which the fund was developed. Generous support of this fund has been received from the Safety Call in honor of Dean Speedy's support for their efforts establishing themselves as an educational resource to support training of health science students, including pharmacists, within the Tox Center. Safety Call represents leaders in adverse event management and regulatory compliance services, and through their long-standing support, we recognize and thank both Drs. Leo Sioris, Chief Executive Officer of Safety Call and Professor in ECP, as well as Dr. Rick Kingston, who's the President of Regulatory and Scientific Affairs and Clinical Adjunct Professor in ECP, for their enduring engagement and support in ECP and the College of Pharmacy overall. As Department Head for ECP, I speak for all of us in being thrilled that Dr. Vieth was able to visit from Canada here and is willing to share his expertise with not just our faculty, but our students and guests from other departments and abroad, and individuals at Safety Call themselves who are watching this on Zoom, to share his expertise with all of us here today. Here to introduce Dr. Vieth is our own Rick Kingston. Go ahead, Rick. I'll just pass it to you live there.
Thanks very much. Well, I feel very privileged to introduce our speaker today, Dr. Reinhold Vieth, who is a professor emeritus from the University of Toronto. He received his Bachelor of Science in Medical Sciences, his Master's of Science, and a PhD both in physiology from the University of Toronto as well. I know him best for all of his research on the topic of vitamin D. I don't know of anybody in the world that has the level of expertise that he has. He has an extensive publication record in excess of 150 publications related to vitamin D research in highly ranked journals, approximately 20 book chapters, and certainly numerous presentations and special lectures. I met him about 15 years ago, and soon after I heard his first lecture that he presented at the Council for Responsible Nutrition, I started using vitamin D in a major way. So you'll hear a lot about that today. He's going to talk about the safety, the efficacy, some of the challenges from a regulatory perspective. And with that, Dr. Vieth, I'll turn it over.
I guess you could say I'm a vitamin D missionary, because he got converted and takes, well over 2,000 units of vitamin D per day. But, you know, you can buy rat poison that has vitamin D in it. Did you know that vitamin D is a poison? You probably do. But, you know, it's extra good for rats because they don't, well, certain reasons. What I want to put you into is, like, pretend that you are an expert and people are asking you to be a consultant in a legal case because somebody that you know says they've taken too much vitamin D and you want to sue the company for making them poisoned. But first, I want to give you a little bit of a, you know, just basic background. Do you think I'm better off using just that? Sound quality is just improved, we hope. Okay, this is basically a diagram. The heavy arrows in this figure indicate the movement of calcium, you know, back and forth with regard to bone, the kidney, and the intestine. You absorb calcium from your intestine, and the thin arrows here are stimulatory signals, and the dotted lines are inhibitory signals. So one thing that you see pointing down here at the intestine is this thing called 1,25-dihydroxyvitamin D. It's a hormone made from the sunshine vitamin, vitamin D. The other key hormone that relates to calcium metabolism is parathyroid hormone. Think of it almost like an insulin-type molecule. It's a peptide. It has a relatively short half-life. Parathyroid hormone tells the kidney to make that active 1,25-D hormone, And parathyroid hormone also tells your bone cells to dissolve themselves, to release the calcium. Every month, did you know that you dissolve away 1% of your skeleton, and every month you put back about 0.9% of your skeleton? So there's a kind of a dynamic going on. You need vitamin D in order to produce the hormone that helps you absorb calcium from your intestine. You do not want to absorb all your calcium. Your dietary recommendation for calcium is about 1,000 milligrams a day. How much do you want? 200 milligrams. And it's an adjusted process. You don't want to absorb 500 milligrams of calcium because it'll give you kidney stones. This graph shows you urine calcium concentration on the y-axis and a survey of adults with different 25-hydroxy vitamin D levels. And the thing I want to point out for you is when you've got low vitamin D, more vitamin D helps you absorb calcium better and put it into your urine. Your body's in a calcium equilibrium. What you eat and absorb goes out into your urine or stool. There's a middle range where you take more vitamin D and it doesn't do anything. Like you've got just the right amount of what you need. And of course, if you become toxic, you'll get too much calcium absorption, maybe potentially hypercalcemia. So there are 3 phases. The hypercalciuria diagnosis level is indicated by the line I just dropped there. Here's a different kind of graph. Initially, more vitamin D, more serum, 25-hydroxy-D, the measure of vitamin D nutrition. Initially, more of it raises your absorption fraction of calcium, and eventually the amount of calcium you absorb is steady, even though you may be getting more vitamin D. It's stable, the way it's supposed to be in a regulated system. But we don't know what happens when you get too much, because eventually too much is too much. So again, what is vitamin D? It's a sunshine vitamin, and this is a kind of a cartoon, but it's just to highlight that you and I are the naked ape. There's evolution that happened through life, and actually what you're doing right now is very unnatural. You're probably sitting there at your laptop, and you're wearing clothes. You've got a vitamin D factory in you, and it responds to sunshine. So what are you doing here? Where did you come from? Where do our relatives live? This is a map of the world indicating the regions in which our relatives, apes and monkeys, naturally habitat. And where did we come from? Our species originated around Ethiopia. This is where we came from. The first human beings, what color was their skin? Was it white like most of you? The natural default color of the skin of the human species is black skin. It's good. It makes the right amount of vitamin D for that environment. It protects you from sunburn. It's a natural sunscreen. Furthermore, here's a different kind of a graph. It shows you latitude, the equator's here, and the y-axis is how light is the skin of the individuals in the populations surveyed. So as you go south from the equator toward New Zealand, the people who live there traditionally have lighter colored skin. And of course, as you go northward in the world, you can see that the people who traditionally live, let's say, 60 degrees latitude in Scandinavia, Swedish people, they have white skin. Why on earth would skin get whiter when you move north or south in the world? Isn't it healthy to have black skin? Well, the skin is, of course, the place where vitamin D is made. There's melanin deeper down in the skin. There's a different pathway to synthesize cholesterol within the skin. It's not the same pathway that is used by the liver to make cholesterol. In the skin, cholesterol synthesis goes via a compound called 7-dehydrocholesterol, which is an unstable molecule. So while your skin is synthesizing the cholesterol that it naturally needs, it goes through a stage where ultraviolet light will break it. It'll break open the steroid, and you have what's called a secosteroid, a broken open steroid molecule, which through non-enzymic means becomes the compound that you and I recognize as vitamin D. You can acquire vitamin D from the food that you eat, but even in fish, they acquire their vitamin D essentially via sunshine through the zooplankton that's closer to the ocean surface that the fish are eating. So biological vitamin D comes from life that we consume, and actually we don't consume very much vitamin D. Okay, you can say, well, how about Scandinavians and Eskimos who are living in sunless climates? Well, how much fish do they eat? They are a fish-eating culture, and they eat thousands of units of vitamin D in the fish. But how much fish did you eat? Did you have a pound today? Sorry, you don't have enough vitamin D in your diet. You go out into the sun, okay, you've got this factory making vitamin D. How much sunshine do you need? You need ultraviolet light in order to break open 70 hydrocholesterol to make vitamin D. Okay, how much ultraviolet light have you had lately? Well, one easy index is the shadow rule. On a bright day, in order to make vitamin D, you need the sun to be higher than 45 degrees above the horizon. And it just so happens, if the UV index is less than 3, the shadow happens to be longer than you are tall. And if the UV index is less than 3, you can go out with your bathing suit, lie in the sun, you won't get much vitamin D. In other words, your shadow has to be shorter than your height in order to produce sufficient vitamin D from sunshine. And if you don't have enough sunshine, as Africans migrated away from tropical regions, they didn't have enough vitamin D because they have a natural built-in sunscreen. Very type 6 skin has almost a built-in UV blocking agent of about 6 compared to a white person. And if you don't have enough vitamin D, you end up with rickets. Okay, so what? Bent bones, but there's something worse. A girl that develops rickets looks more like this, and she will not have babies. Why would rickets prevent you from having a baby? Because it's not just the long bones that are bending, it's your pelvis. And if your pelvis is too narrow, you have what's called cephalopelvic disproportion. In other words, the baby's head is too big for vaginal delivery, and you die in childbirth. So this is a natural selection for what? People who have the ability to make more vitamin D from sunshine. And what people are those? Those who in northern latitudes have lighter skin color. So vitamin D is why many of us have white skin. Sun protection is why many of us have black skin in tropical regions. The way a person looks is just a factor of the environment. There's no such thing as race. So I just want to get into the pharmacology of vitamin D right now. And the way I think about it is buckets, pails with holes in the bottom, okay? You've got a fluid passing through a sequence of buckets. Some of these buckets, for example, vitamin D goes into a compartment or a bucket, and that bucket has holes in it. Through relatively easy processes, your liver makes something called 25-hydroxy vitamin D. If you take a vitamin D pill right now, it'll keep your blood vitamin D level up for about 2 or 3 days until it's cleared out of the system. But that vitamin D is largely converted to the thing we actually measure for vitamin D nutrition called 25-hydroxy vitamin D. And so far as we know, 25-hydroxy vitamin D does nothing. It is the official measure of your vitamin D nutrition status. It does nothing. Why? Because 25-hydroxy D is used largely by the kidney to make that special hormone that you need to absorb calcium through your intestine. Okay, so you've got a regulated thing for something extremely important, to regulate calcium. The most tightly regulated thing in your bloodstream is calcium. Its coefficient of variation is about 3%. If you hyperventilate, you might get a sense of what it feels like when your calcium is off. Your hands will start tingling. If your calcium is too low, you'll have issues as well. You'll become hyperreflexive. Calcium is a thing that can kill you if it's not regulated properly, and the vitamin D system is very important for that. Within various tissues of your bodies, you also have this 1-hydroxylase that can make this hormone, 1,25-dihydroxy vitamin D, and it's used for local paracrine regulation. At tissues, the 1,25-dihydroxy D improves differentiation, makes a cell become what it's supposed to be, and it reduces proliferation. So the if you have a bad cell, a cancer cell, it won't proliferate as much. So vitamin D has, at least in the test tube, good things going on for it within tissues that have nothing to do with calcium per se. Lastly, there's a clearance system, this 24 hydroxylation of both 25-hydroxy-D and 125. So you've got a flow-through system. And I argue that this is very different from the system by which estrogen or testosterone or cortisol are regulated. Recognize, what's the hormone concentration here? Picomoles per liter. Cortisol, estrogen, testosterone, they're all nanomoles per liter. The other steroid hormones you're familiar with are present in 3 orders of magnitude more concentration than this potent little hormone 125D in the vitamin D system. So again, vitamin D has a half-life of around 2 days. In vivo, it appears to have a half-life of about 2 months, but that's because it distributes into a large volume of distribution, both muscle and adipose. And recognize also, vitamin D binds to a specific carrier protein called vitamin D binding protein. It's also called group-specific component, GC, which is the most polymorphic, polygenetic marker within your protein system. Everybody's different in terms of GC genetics. The other interesting thing about vitamin D binding protein has a second function, actin binding globulin. When you have a car injury, you've hit your muscles or whatever, you've got this bad protein called actin floating around that can polymerize. What prevents polymerization? Binding to vitamin D binding protein and clearing out that actin from the injury. So there's a lot of things that are going on in this system. So 25-hydroxy vitamin D has a very large volume of distribution. You can say, yeah, it sticks into adipose tissue, but its concentration within muscle tissue is just as substantial. And you can say, well, but women have 50% more adipose tissue per kilogram body weight than men do. But the biology of vitamin D is the same whether it's a man or a woman because it's a very large volume distribution. Muscle or adipose are very similar. If you join the Navy, or used to be, there are a couple of studies that were done of sailors that went into 2-month submarine missions, and they measured their 25-hydroxy vitamin D blood test result without taking a supplement. The level went down by a half. In other words, the half-life of 25-hydroxy vitamin D, if you deprive yourself of sunshine and don't take supplements, is 2 months. It lingers a long time, but that's still a meaningful amount of of change over time. Finally, the 125-dihydroxy vitamin D, this potent hormone, has a half-life of about 12 hours. It sticks pretty much within the bloodstream, and it is the sharp end of the vitamin D knife. It's the thing that does the action, okay? So if your vitamin D toxic, it's because you've got too much 125-dihydroxy vitamin D present. And lastly, there's a breakdown product called 24-25-dihydroxy vitamin D. It's about 15% of the 25-hydroxy concentration. But this stuff breaks down to 24-25, and its side chain is cleaved off and just gets dissolved away like a lot of other things through hepatic excretion. So you've got a large volume of distribution, a slow turnover for vitamin D within the body. There is saturability. Vitamin D binding protein, interesting compound. The frustration about people in Canada, because we work in SI units, molar units. If you're looking at a protein in the United States, they go, how many grams per liter of protein do you have? Which to me is nonsense. What's much more important is how much vitamin D binding protein do you have? And your circulation has the vitamin D binding protein capacity to hold 5,000 nanomoles per liter. Tightly. The 25-hydroxy D is bound to a protein that can hold 5,000 nanomoles per liter. Interesting. I'll get to that point later. So, obviously, if you intoxicate yourself, your 25-hydroxy D should probably be more than 500 nanomoles per liter. And it's the free, unbound 125-dihydroxy D hormone that's the sharp end of the knife. Unbound, not stuck on DBP. So again, the other thing I want to point out is you've got a flow-through system with enzyme regulation. And because the 25-hydroxy D substrate is at such tiny concentrations, the enzymes work in what's called first order reaction kinetics. You know what that means? If you double the amount of raw material you bring into the factory's going to produce double the amount. If you've got saturated enzymes, like a factory, it's already much too busy. It can't handle more raw material. Here's an example. They don't do the experiments like this anymore. This was done way back in the 1980s. This is calcium deficient rats, and they were given a pulse injection of 25-hydroxy-D. And the interesting thing here is the amount of this potent hormone went up in response to an injection of raw material, totally in proportion to the amount of raw material put in. If you doubled your cholesterol intake, is your estrogen going to go up? Testosterone, cortisol? No. But with the vitamin D system, if you put in more substrate, more product happens, whether you're looking 3 hours after injection or a day later. And the other interesting thing is we measured the enzyme in the kidneys when we sacrificed these rats. And this is the 1-hydroxylase enzyme within the kidney of those rats you just saw some data for. And this is the percentage yield of the hormone in the bloodstream that happened during this previous day. And the amount of hormone production, the percent hormone production, was a direct correlate with the amount of enzyme in the kidney. So you've got enzyme that's below substrate producing a potent hormone. And this has something to do with vitamin D toxicity. Now, with regard to toxicology, the father of toxicology is named Paracelsus, and he's famous for the phrase, if anybody ever asks you on a trivia question, what's the famous phrase of the father of modern toxicology? You go, the dose makes the poison. I like to paraphrase it. If something actually works, too much of it will hurt you. Conversely, if it's useless, it's absolutely safe. So, take your pick of it. Now, it's very hard to find cases of toxicity with vitamin D these days. So here's a paper from 1946 where they summarized all the case reports of people with vitamin D toxicity. In that era, they really didn't know much about doses. They say, well, we're going to give 1 milligram of this stuff to somebody, maybe 2 milligrams to that person, forgetting that 1 milligram is 40,000 units of vitamin D. And here are the symptoms of hypervitaminosis D. You get thirsty, you become anorexic, you vomit, you're tired, you've got malaise, all due to hypercalcemia, of course, right? Too much calcium. Why are you thirsty? Because you're trying to excrete the excess material. You have nausea, headache, constipation, abdominal pain. And the doses here that were used were well over 40,000 units per day and for weeks and weeks and weeks, right? This is a nice paper. It gives you context. As a laboratorian, I worked at a biochemistry laboratory in Toronto. There were some collaborators that were wondering what's going on with this man. He's a 29-year-old man, admitted to emergency the first time. He had right side flank pain, dry eyes, conjunctivitis, thirst, vomiting, renal failure. And the emergency doctors, you've got gastroenteritis, come back. You'll be feeling better before you know it. Well, he came back and they actually measured the serum calcium that day. And his calcium, sorry for the SI units, but 2.5 millimoles per liter is normal. His calcium was very high at 3.8 millimoles per liter. So they sent, trying to figure out why is there hypercalcemia in this patient with gastroenteritis. Well, they measured the 25-hydroxy vitamin D, and it came out as 1,555 nanomoles per liter. I will bet you the average one of you, if you did your blood test right now, would have a value of about 60 nanomoles per liter, or an American number is 22 nanograms per milliliter. So you've got something that's like well over an order of magnitude beyond the upper limit of normal for this person. So it became a mystery. And incidentally, that potent sharp end of the knife, the 125 dihydroxy-D, was pretty close to normal. It was only marginally higher. So what's going on? Why does this person have a high blood calcium? Well, we got a blood sample and ran it on a liquid chromatograph. This is an ultraviolet spectrum. And for 25 hydroxy-D, this 1,500 nanomoles per liter showed up very nicely with a classic vitamin D spectrum at the right elution time on the HPLC. We could see the 25 hydroxy-D, but what I'm not showing you is the best part. His vitamin D spectrum looked spectacular. Like he's got 7,000 nanomoles per liter of vitamin D in his bloodstream. You can see the vitamin D spectrum beautifully, and what I just showed you, that little line, was this one here. It all depends on how you run the scale. But this person was grossly intoxicated, and we had to figure out why, where. So they sent me all sorts of foods from, what these people were eating, because it turned out his dad had the same problem. So why does a young man and his dad show up with hypercalcemia and ridiculous vitamin D levels? So he looked at all sorts of foods. And we, one of the things I did was put the table sugar that they provided into just some water, and suddenly the crystals were floating on the top, and you could dissolve the crystals. They were pure vitamin D. Their table sugar had about a milligram of vitamin D per teaspoon. And this happened that, and I'm not allowed to tell you, but nobody knows who these people are now. The girlfriend, when she got mad at him, somehow had from her workplace crystalline vitamin D that she spiked into their table sugar. So they were taking about 1.5 million units of vitamin D whenever they had a cup of tea. And they had a ridiculous high vitamin D level. So this is just, how high it has to be. With that high of vitamin D and 25 hydroxy-D, was saturating that vitamin D binding protein and releasing the 125 hormone. Even though its total level looked normal, the free level was very high. And a year later, he was still going out with the girl. True. Hypercalcemia, if you've got the question of hypercalcemia, okay, what does it mean? Well, if you run a laboratory and you've got a new lab test, hey, you've got a new calcium. What's the normal level of calcium? You know what you do? Find 100, supposedly normal people, do the blood test. The top 2.5% have hyper, the bottom 2.5% have hypo. In other words, normal is 95% of the normal population, right? So by definition, 2.5% of you have hypercalcemia. You go, I feel fine. Who says I've got hypercalcemia? But it's just a sort of normal thing, right? It's asymptomatic. And this is just putting it in as a confirmatory publication if one wanted to look at. But the way laboratories determine normal is normally the 95% confidence interval. Now, vitamin D toxicity, when looking at it, policymakers fixate on hypercalcemia, which I would argue is 2.5% of the normal population. And often you get cases where somebody says, I've got hypercalcemia, and the person's taking 5 vitamin D pills because the manufacturers instructed it or the doctor instructed it. That hypercalcemia, I'm going to sue the person who told us to take that much vitamin D. And they come to you, and this happened to me. You get, you're an expert consultant, and lawyers will call you and say, I've got a case that I'm trying to try of a case of hypercalcemia, and we think the vitamin manufacturer was poisoning people. And then, well, what was the dose? What was the situation? As an expert, you respond back, I don't think that's likely to be causing vitamin D toxicity. And the lawyer is going to say, okay, I'll maybe call you back later. Well, what you just gave up was a $600 an hour job, because that $600 per hour as an expert witness builds into thousands of dollars that you just wasted. I mean, if you wanted to cheat, you could have made money. So what you really need is some index that proves beyond reasonable doubt that a high vitamin D is actually causing hypercalcemia. Years ago, I surveyed occurrences of 25-hydroxy-D and related it to patients who, in case reports, were stated as having hypercalcemia, and that's these X's up here. And the people who were suggested to have been the result of hypercalcemia due to vitamin D were taking 1,000 micrograms or more of vitamin D. That means 40,000 units or more, or a milligram or more of vitamin D per day. This is just case reports. It doesn't prove anything. A lot of people were normal, these white dots, taking the same dose. So you can't really prove, based on case reports, that you've got anything going on. And incidentally, on a nice day, of what's called the minimal erythemal dose, the amount of ultraviolet light that will not quite turn you red, introduces into your body the equivalent of having taken 10,000 units of vitamin D3 on a given day. That's a substantial amount and much higher than roughly the 600 units that's likely to be in your vitamin D pill. A quart of milk has 400 units. You'd have to drink a lot of milk to make up for what you could get if you were not sitting in this class and instead, sat in a nice time outside. Most hypercalcemia, quote, is asymptomatic. It might even just be part of the upper normal range. It could represent primary hyperparathyroidism, it's kind of an adenoma or cancer of the parathyroid gland, which is something that should be treated. It could be cancer. Probably the most common cause of hypercalcemia is that there's a metastasis at the bone, releasing the calcium from the bone. And of course, vitamin D might be causing toxicity, but how do you prove it? It's a legal issue, and you have to prove something beyond a reasonable doubt in a courtroom. And I could probably talk you out of thinking something is vitamin D toxic the way I'm talking, I'm hoping. What I want to also remind you, if you have anything to do with pharmacy and modern technology and terminology, is a sort of a real grudge of mine. The terminology has become extremely sloppy by physicians and everybody when it comes to vitamin D. They forget that there's a difference between vitamin D, 25-hydroxy vitamin D, and 1,25-dihydroxy-D. If you provide a prescription in most pharmacies for vitamin D, it'll be for calcitriol, 1,25-dihydroxy-D. Why? Because it's a hormone produced by the kidney, and people with kidney failure require replacement hormone for that kidney hormone, 125. So it's easy to screw up and call that kidney hormone calcitriol. I misspelled it. 1,25-dihydroxy vitamin D is calcitriol. Calcitriol is a hormone, not a nutrient, and don't get them mixed up. When you hear the word vitamin D, ask yourself, what exactly are we talking about? And it's not a trivial thing. It seems obvious when you're sort of talking in this context, but people make mistakes about the terminology and always know where you are on that bucket list that I showed you earlier. So right now, nutrition policy, the way government guideline is set, this is, the way the Institute of Medicine talks about nutrients. As you have increasing doses, daily intakes, you have some sort of average requirement that doesn't suffice for everybody. The recommended dietary allowance is around 600 units per day for you guys. There's something called the upper level, the tolerable upper intake level that anybody could take in and be virtually guaranteed by the government they're not going to poison themselves. There is something called the no observed adverse effect level that has a safety factor built in to produce an upper level. And then you've got something called the lowest observed adverse effect level. What level of intake can you be pretty sure causes harm to a person? And that harm index is usually called hypercalcemia. But where does that happen? Has anybody titrated it? So Currently, the upper level, the highest intake that you can reasonably take based on government is maybe 10,000 units per day, but you don't tell people that because you need a margin of safety, et cetera. So again, getting back to my question, objectively, if you were in a court of law, how could you prove that hypercalcemia is caused by a high vitamin D? And I was very lucky to be connected with and provided by a group in Edmonton, Canada, where there was a sort of a well-intended clinic called Pure North Synergy that provided high amounts of vitamin D and then encouraged high intakes of vitamin D. They had thousands of participants, essentially healthy people, who were in a study or in a clinic that was providing health care and nutritional supplements. So there were 4,700 people who provided blood work between 2012 and 2013. What I did, I had their 25-hydroxy-D levels, and before actually doing any statistics, I wanted to take it in 50 nanomoles, which equals 20 nanograms in American numbers. In 50 nanomole increments, at what point does the calcium actually go up in people if you've got a large sample size? So as a result, here's kind of an overview. These are, I had 941 people with vitamin D levels less than 20 nanograms per milliliter. The normal group is these 50 to 100. I had 2,000 people as such as that. And there were 29 people who had a blood test result higher than 300 nanomoles per liter. So the 25 averages went up to almost 400 nanomoles per liter, or about 660 nanograms per milliliter in American units. These are average calcium levels. Calcium was actually a little bit lower in the group with less than 50, which is to be expected if you don't have enough vitamin D. This is the reference group, 2.37 millimoles per liter. And going all the way up to in the 250 range, there was no statistical increase in calcium. However, in those people who had a 25-hydroxy-D over 300, there was a statistical increase in calcium. You can't read it very well, but it's these subscripts that I put into the statistical analysis. These are the average levels. Again, the same data as you saw, just in graphical format. Once you get over 300 nanomoles per liter, I can't translate mentally at this moment to US. Once you get over 300 nanomoles per liter, you get a statistical increase in calcium. Now, one of the problems was when you're doing lab work, you have a stated reference range that the laboratory provides. And sometimes your reference range, if you've got 4,000 people, ends up being a little bit different than the laboratory's reference range. So to do what's called a sensitivity analysis, what if kind of thing, I reworked the results in multiple ways. And regardless of how I reworked it, the index was that if your vitamin D 25-hydroxy-D exceeds 300 nanomoles per liter, you go from a typical rate of hypercalcemia that's around 5% to triple that. In other words, when your 25 exceeds 300 nanomoles per liter, you've got a triple probability of having hypercalcemia. So that's my index. I blame vitamin D toxicity if their blood test result is higher than 300, or I can't do my mental math at the second. I'm just trying to move along because I see the time moving on. So hypercalcemia is asymptomatic. A high vitamin D could cause toxicity if you're way above the, the biological range. Vitamin D is toxic. It's toxic in milligram amounts, which doesn't sound much, but vitamin D, you'd measure it normally in microgram amounts. What about population health surveys? I'm changing here. You go, well, what's vitamin D good for other than bone? And there's a very nice meta-analysis of meta-analyses. And the purpose of this particular slide is just simply to summarize, in cross-sectional health surveys, a meta-analysis is comparing rates of disease, in the high vitamin D group versus the low vitamin D group. And basically this graph, if there were no difference, the confidence interval lines would not cross this 1 ratio. That vertical line represents 1. The highlighted line indicates 0.5. In other words, for this particular study related to prostate cancer occurrence, higher vitamin D group had less prostate cancer. And you can look, there's cardiovascular disease, depression, diabetes, fracture rates, and not exactly mortality, but there's a variety of diseases in which vitamin D does benefit. Problem, if you present this, people go, that's a population survey, it's useless. Give me please level 1 evidence. You know, in medicine, level evidence is taken from level 1 down to circumstantial, which is like level 3. You know, you may have opinion, cohort, you've got randomized trials, systemic reviews of randomized trials, etc. So people demand, policymakers demand the utmost in evidence, okay? But I want to get to you the concept that demanding the most evidence is not realistic. For example, if you had a drug clinical trial, you'll have a placebo group, you'll have a treatment group. You will choose people who are at high risk of disease. In other words, you'll take, people who've had a heart attack, put them on a drug, and see subsequently whether placebo has more events than your dose. Or you'll get osteoporosis patients with a fracture, and you'll look subsequently whether your new drug reduces fracture rates or falls or some outcome, right? So you're selecting people for existing conditions that are highly motivated to take your drug. You're going to follow them up for no more than 5 years because the graduate student wants to be done in 5 years, right? And you're going to look for high likelihood of event. What about nutrition studies? Nutrients. Okay, if you compare a drug study like this, you got placebo and dose. With a nutrient, no. It's not ethical to have placebo. You have to keep them on whatever they're taking or the RDA. And then you add a little bit extra to see if that does anything. So you've got a much smaller dosage window with nutrients than you do for drugs. And other problems. Are you as a healthy person going to volunteer to take something whether you know it's good or not? Here's a pill. Maybe it's good, maybe not. It might be placebo. And you're going to do this for how long? Oh, that disease, let's say cancer or multiple sclerosis, might take you 10 years to detect. Are you going to take a placebo or a therapy for 10 years? And there's no graduate student wanting to wait 5 years for you to take your drug for 10 years. Doesn't happen. And also, how likely is it that you as a young, healthy person are going to take something and have a disease event like a bone fracture, cancer, heart disease, stroke? Nothing. Low probability of event. It doesn't happen. Multiple sclerosis. I don't have time to show you all the background detail, but in 2011, I was one of 20-something international researchers asked by the National Multiple Sclerosis Society of America to come to a conference whose purpose it was, can you come up with a research fundable study that could demonstrate that taking vitamin D reduces risk of MS in people who don't have it right now? MS is a horrible disease. So, conclusion, no way. We can't study whether vitamin D reduces risk of MS. Why? Do a power study. In a given year, 10 out of 100,000 people will end up with MS. Okay, you've got an event rate of 10 per 100,000 people years. It's extremely difficult. So you've got a proportion of something happening. This is using, I love this program called G-Power. It's a free program. Just look it up on the internet if you do want to do power studies. It's quite a high-level program. So you've got a control treatment group. You think that this population, 10 in 100,000, is going to end up with MS per year. How much is your randomized trial going to lower the risk of MS by? You know, okay, optimistically, turn it down by a half, maybe more, maybe less. But just reduce rate of MS in a healthy population by 50%. Okay, and you're just even going to power it to only 0.05, which is not a bad power, alpha error. Well, it turns out you crunch the numbers, you need 1 million patient years, 1 million patient years of randomized people to find out whether whether vitamin D prevents MS. It's not going to happen. And basically, you need 40,000 people. You'd have to study them for 15 years. No granting agency really gives much more than 5 years. No graduate student wants to do more than 5 years of work on a research project. It doesn't. And then, of course, you've got a healthy population. Here, take this. Oh, darn, I forgot for the last month. Oh, yeah, I think I'll take it now. Or, oh, I got a better vitamin. And, people will change their minds during the study. You cannot do primary. In other words, primary means that people never had the disease before. No history of it. And then you got to see whether it prevents a disease in the future. It's not the same as a drug trial that can produce level 1 evidence. You need less level of evidence for nutrients. It doesn't happen for nutrients. So I'm just now, ending up with a talk with a couple of policy-related things. One of my best, most cited articles was this 2007 article. It was an editorial in American Journal of Clinical Nutrition asking for a new RDA group to be established by the Institute of Medicine to review guidelines with regard to vitamin D, because at that time it was 200 to 400 units per day was recommended for you. 200 to 400. You're making 10,000 in sunshine. I had 14 co-authors, 14 people that I thought, oh, these are really powerful people in the vitamin D field. They know about it. One of the people I asked said, Reinhold, I don't want to put my name on that article because I'd like to be on a policy committee. And if I put my name on that, I'm not going to get on any committee. I thought, what a ridiculous thing. Come on. Just because you say you like something doesn't mean they're going to throw you off the committee. Well, the committee was formed, and not one of the 14 people that I had as co-authors was on it. If you are an advocate for something and the government is taking a committee, they're not going to call you because you've already set your perspective. Well, at that time, just to keep it short, because I've got a few of these to go, the recommended dietary allowance set in 2010-11 was designed to keep your blood vitamin D test result higher than 20 nanograms per milliliter. Average Americans might have, 25 to 30 nanograms per milliliter, fine, but none of these people were on my group. I felt sorry for some of the ones I asked because I kicked them off of the ability to be on a committee. And the 2010 FDA committee said you shouldn't have vitamin D levels more than above 30 nanograms per milliliter because there's a double-blind placebo-controlled trial that says people who take vitamin D get more bone fractures. More bone fractures. Wait, I'm trying to reduce fractures or reduce the number of falls that they have. I misspoke, it's fractures. People who took vitamin D had more falls. They fell down more often than people who didn't. So that's one reason why in 2010 they kept the RDA relatively low. But actually look at the study that was the basis for that. And you know what they were doing? Once a year, they gave them 500,000 units of vitamin D. Can you imagine any other agent? Iodine, vitamin E, give me a nutrient, anything. Once a year, take a dose. It's going to do you any good. I would say you overdose yourself once a year. And indeed, that's what happened. Because when they took this once a year dose, for the 3 months after the dose, there were more fractures and falls on a cyclic basis. Their vitamin D levels pulsated after every dose. And this is another form of toxicity. It's a more incidental, it's not hypercalcemia, but another adverse outcome. You can't cover all the bases, but sometimes there are reasons why bad things happen. So I'm saying you give a year's worth of anything, something will be a little bit excessive and you think foolish because they really haven't looked or thought through the science behind the model. Remember, I was showing you the enzyme kinetics for the vitamin D. You pulsate the 125 production. Okay, now comes the year 2011. Mike Hollick, who is a vitamin D advocate, was asked by the Endocrine Society of the United States to come up with a new guideline for physicians about vitamin D, cholecalciferol supplementation. And just to keep it short, they recommended enough vitamin D to keep your blood test result more than 30 nanograms per milliliter. The Institute of Medicine on the page before said 20 nanograms per milliliter. There's a kind of a difference between what's healthy. Okay, so the Endocrine Society in 2011 said 30 nanograms per milliliter. Lo and behold, this last April comes another Endocrine Society of the United States review. It was different. Oh my goodness. They lowered their target level back down to 20 nanograms per milliliter for endocrinologists to taking care of patients. What the heck is going on? Like the Endocrine Society goes one way, back another. Oh, did I tell you that there's another Endocrine Society committee that also almost this simultaneously, this one was from Europe. It's a different group of people. And again, they're back to 30 nanograms per milliliter. I'm sorry to, share my frustration with this, but what are you or the public supposed to think? Or physicians, pick your recommendation. Do you want your blood test result to be 30, 20, 30, or 20? Like, what the heck? And here's my conclusion. If you want a committee to come up with a recommendation, be very careful about who you choose to be on that committee. If you don't want a high recommendation, do not select advocates. And I've talked about this with a colleague of mine who teaches at the business school. He says, oh yeah, everybody knows that. There's a nice paper by Myers and Lamb. Group discussion amplifies the a priori thinking of group members. In other words, okay, finally you got a committee. I chose that committee. I know who thinks what. And by talking about it, that committee actually amplifies. They justify each other on their presuppositions. And I just want to put in that little proviso thing at the bottom. If you want a committee to come up with a decision, think about what happened with your Supreme Court. Okay, thank you.
I think we've got a few minutes for questions. Anybody?
Yes, sir.
One of the situations that we have here in the United States is the Centers for Disease Control is in Atlanta, Georgia. When they do studies, whether vitamin supplements help or not, they get results that say they're not statistically significant. Therefore, the Swiss Canadians have gotten it wrong. It has to do with how deficient your controls are. How do you handle?
Yeah, well, actually, when it comes to nutrients in a lot of health policy, Canada and the United States, they kind of work together. So, and Europe tries to follow the US in the context of nutrition. Your question was, why do they keep saying there is not sufficient evidence for? And that was what I was trying to belabor by comparing the methods by which a pharmaceutical active agent given to patients has a different kind of study involved than a primary disease prevention study, like the example with multiple sclerosis. The people who demand and say, I mean, it's so easy. Every time I see a news report on vitamin D is great, and they go, oh, yes. And then we've got the other side, and it's some guy, there's not sufficient evidence. There's not level 1 evidence here. You go, give me a break. Who on earth funds level 1 quality evidence for primary prevention of any disease? It doesn't happen. Have you ever seen a primary prevention study of cigarette smoking? It doesn't happen. You're not going to put people into studies that last 10 years smoking. How long does it take to hurt you? It'll take a lifetime. And likewise with nutrients, the evidence that people demand is never there. So to sit there smugly and say, well, we don't have sufficient evidence is a cop-out.
But vitamin D is different in the.
No, vitamin D suffers from the same disease.
It is different in that people in Texas do not get vitamin D deficiency, and therefore your control population is not deficient.
There's a ton,
Therefore, there's no statistics. This doesn't
it's,
happen.
well, it's a fun area because it's not just covering nutrition, it's covering sun exposure. And there are epidemiological cross-sectional surveys, for example, prostate cancer and breast cancer, where you do a incidence map across the United States, and the lowest rates are in the south and the higher rates of cancer are in the north. They correlate with latitude. And there, it's not vitamin D nutrition, it's just sun exposure. Like farmers, on average, have a 25-hydroxy-D level of 30 nanograms per milliliter, 75 nanomole per liter, on average, which is substantially higher than what clothed people like me would normally have if they weren't taking a supplement. Like the demands that people cite is basically unrealistic demands.